the prediction after the treatment, can we be able to predict the outcome after the treatment? So karibuni sana. That was just to mention some of the things I would urge that we check as we move along, so that by the end of the day, we will be able to know, have we been able to understand. So when we go to addiction, and I normally like teaching it in an engaging manner, so that we can learn together. Maybe one or two of you could maybe mention, what do we know about addiction? If someone asked you what addiction is, unaweza sema ni nini in the plain language ya vile wewe unaijua. Anyone? You can raise your hands in case you want to try what you know addiction is in your own knowledge. Do you have anyone? One or two people? Anyone? Yes, Marianne?
My understanding of addiction is something that you start and eventually you cannot stop. For example, my brother started betting and he got addicted. He cannot now stop, and it's ungovernable. To me, that's my understanding of addiction.
Okay, thank you. Yes, Esipa. Thank you so much, Marianne.
Addiction is the act of being unable to control yourself over something. Yeah.
Okay, thank you so much. Did I see someone else? Something Esipa insurance? Ama ni yeye tu? Okay. Well, it is true. As you say, there is an element of it. Nitataka kudefine kwa ile lugha rahisi sana so that we can build on that. Addiction. Number one, addiction is classified or categorized as a mental illness. Ni ugonjwa wa akili. That is the category of classification. In the category of the addiction, we are looking at how we are looking at what is the real outcome. Yeah, if we look at the areas affected, the classifications comes to be a mental illness. And now, as you said, someone said it is where someone starts something and then they are not able to stop. And maybe if you look at what we see for us to know there is a problem of addiction, then we could also try looking at what is coming through or what is coming up after we look at the process of how it happens. How do we know that something is happening? How do we know that there is a problem? Number one, wakati mtu anafanya kitu ama anatumia, because like Lewis has said, addiction is both using of chemical substances, and also it is when we look at the issue of that inability to stop. So there is the behavior, either mtu ako na tabia ambayo hawezi kukaa bila kufanya, ama anatumia vitu ambazo hawezi kukaa bila kutumia. Right? Basically, you're depending on them. And so the other thing you can look at when you talk about addiction, we say that it is characterized by relapse. So relapse means that it is something that keeps on coming back. Inaisha ikirudi, inaisha ikirudi, inaisha ikirudi. Normally ni kama vile tunaweza sema mambo ya hypertension or maybe like diabetes. These are not things we say we cure or they get away from us. They are things that keep on coming back. Leo iko sawa, kesho haiko sawa, hiyo siku ingine iko sawa, hiyo siku ingine kuna shida. So when we look at the issue of the issue of addiction, it is something that keeps on coming back. Inaisha ikirudi. In the medical perspective, we call that relapsing. Relapsing is going back to something or to doing something after a period of abstinence. So wakati tunaongelelea addiction, kuna hiyo element ya kukaa shida ikirudi tena na tena. And that tells us something, that if something keeps on coming back, has a tendency of relapsing, then it is something chronic. So for addiction, it is a problem that is chronic, meaning that at the end of the day, we will never say that someone is healed or is cured. The only thing we can do is to contain the problem. So hatuwezi sema ati mtu alitibiwa alipona, hiyo story iliisha. Ni kama tu mtu wa sukari ama wa blood pressure. Hatuwezi sema ati huyu mtu ametibiwa na sasa pressure iko stable, ni hivyo. The moment it happens once, then at the end of the day, we must be very vigilant on observing. That person must remain vigilant, monitor it is, taking care that they do not expose themselves to triggers, just keeping in touch with themselves and the reality of what is happening around them every moment. Because a misquote could mean even loss of their own lives, because it is something that keeps on coming back. So at the end of the day, we have mentioned that it comes with inability to control, and that inability to control means that when someone starts to do that thing, when someone starts to use ni pombe, ni bangi, ni sigara, ni nini, is it the behaviors? Then when the moment they start to do it, they are not in a position to control themselves. Number 3, that they lose power of that control. So we talk of powerlessness. So mara mingi utapata most of the people who are having any addiction, yeye mwenyewe angetaka kutoendelea hivyo, lakini hana uwezo, kwa sababu any moment they are not doing it, they experience what we are going to see as the withdrawal syndromes. So in my definition, now putting together the aspect of what addiction is, sometimes people misunderstand it because there is a treatment gap. There is a very huge gap that happens. And we say that it is only about 11% of people who live with addictions or the substance use disorders that are there that receive treatment. And this is a staggering, the staggering statistics reveal that there is a very high critical gap. Because you'll find like in 100 people who live with addictions, only about 11 of them, at most about 12, who will have a chance to get proper treatment. And this is because mostly there is a very huge gap in the awareness that we create when it comes to the treatment for addiction. Now, this gap that of creating the awareness makes people not really have an awareness of what should happen. So watu wanaweza kuwa wanaona mtu ako na shida, but they don't know what to do about it. They don't know now if the problem is there, where do they go? Number 2, there is a very, very big barrier that comes around again with stigma. And now stigma is also something that prevents so many people to seek help, because they fear the judgment, what people will say about them, the shame that will accompany that that decision to receive treatment. There is the misconception that is going to be there about the addiction. There is going to be the moral feeling that will keep so many people, millions of people, from accessing help, because we have made it look like the people who seek for this help somewhat, and that is what most people look at it, inakaa ni kama shida ya kujitakia. A problem we have not only with the healthcare sector, but even with our government processes. It is now they are starting to appreciate that there is a big problem. If you look at even right now, the kind of insurances that are there, when it comes to something mental illness, they are very skeptical about it. They are not very open to it. They are not very of or having open arms to be able to appreciate that is a real problem. Even the government insurance covers, we realize like it can cover for all the other things, but when it comes to addictions, when it comes to mental illnesses, there is a huge gap, and you realize that it is not appreciated. Why? Because people feel mtu alivuta bangi, sasa sio ni shida yake, ni kukosa adabu, so hiyo ni shida yake, is not a big problem, ni kuacha tu. And people feel when it comes to addiction, you have a problem with addiction. Yes, the only thing you need to do is just stop using. There's nothing bigger. So people feel like it is just a matter of just stopping to use. It's not a big deal, ni kuacha tu kutumia. Mtu kama anasumbuka na kukunywa pombe, si aache tu kwenda club. And most people even say hakuna mwenye inapata nyumbani ama mwenye anawekwa kwa mdomo by force. But there are so many of you even who are here, maybe who are not in addictions of drugs, but there are so many of you who are here mwenye haezi amka na aende kazi kama hajakunywa chai, kwa sababu akifikisha saa 3 atasema anaumwa na kichwa, na indeed ikifika saa 3 anaanza kutofunction. Mimi hata sasa kichwa yangu inauma, ni majani, sikunywa chai. Lakini the same person can stand somewhere and say, mtu kama ako na shida ya pombe si awache tu kukunywa, si aache tu kuenda club mahali iko. You know, people have made it look like it is an optional problem, but maybe with the knowledge we are going to gain, we will see how it is a problem that we need to address together by realizing that it is a disease. Number one, the thing before I go to the brain, that addiction is a chronic relapsing. Actually, we say it is a chronic relapsing brain disease, and it is characterized by powerlessness, loss of control, and obsession to substances or the behavior despite negative outcomes. So hata wakati huyu mtu anatumia na kuna outcomes ambazo tunaona clearly they are negative, you realize that this person is just continuing to do even when they see. Mtu anaamuka na school fees yake yote, anasema wacha nikunywe chupa moja pale, anakunywa yote, anajipata baada asubuhi hana chochote, hakulipa nyumba, hakulipa shule, hawana chakula na iliisha. That is a very negative outcome of what they did. And at that moment they will all be promising, I'm not going to use again, hata nimeacha nini. But then again, tomorrow you realize that they are back to the same problem again. And people keep on wondering, why are they doing that? Don't they see the problem that is accompanying what they are doing or the behavior they are doing? At the end of the day, the problem is not them not seeing it. It is because the problem they are dealing with is a mental illness. Number two, it is chronic. Number three, it has powerlessness, it has loss of control and obsession. And when we talk of obsession, it's something, it's deep love and connection to it that someone cannot even be able to explain or cannot be able to survive without, which is now the obsession that keeps or hides them from looking at the reality. So in real sense, addiction looks like a mask that will only mask someone not to face the reality that is happening around them. And maybe we would want to ask ourselves, what is happening in the brain of this person who is in addiction? Ni nini hiyo inaendelea kwa akili ya huyu mtu ambaye ako na shida? Because something must be amiss somewhere. And the brain, which is now our control center, because we say a person is as good as the brain, you know, you are as functional as your mind is. Without your mind functioning properly, then the whole of you ceases existing or ceases functioning. Now, there are the key regions that govern our behavior, and these key regions that now play a very big role in the addiction process. And the first region is what we are calling the prefrontal cortex. Sorry, the prefrontal cortex is the one that is responsible in our mind for decision making. And the prefrontal cortex is the one that is the front of your brain. If you look at the brain, wherever I'm putting the mouse, is the prefrontal cortex. And normally it is responsible for decision making and the impulse control. And it is also responsible for the rational thinking, which now helps us to weigh the consequences and regulate the behavior in social situation. I will explain that better in a language that is a bit easier. Then we have the reward pathway system. I'm talking of these three areas because they play the biggest role in the addiction. Now, the reward system, normally the nuclear accumbens, the brain reward pathway circuit that releases dopamine and other feel-good hormones. And it is where, when we experience pleasure, the system is normally the one that reinforces behavior, and it is very essential for survival. It can be hijacked by addictive substances or behaviors. I will explain that better. Then we have the amygdala that processes emotions, stress, and the fear responses, and it plays a very critical role informing emotional memories and triggering cravings during addiction recovery. Now, what I mean is that we have these key areas that tend to be affected when we are using the substances we use. And when we are using, you realize that for people who are using the substances or who are having other forms of addictions, they will have their decision-making process normally not very stable. And their rationality when it comes to thinking is going to also be having issues because huyu mtu akona already they have been hijacked when it comes to the things we are going to do as we proceed with the behavior of addiction that comes with us. And maybe niseme kwa the simplest language, what normally happens when we created or the way we were born in this way that our brain enjoys or appreciates any natural pleasure-giving activities. Whenever we do anything that is natural and it is pleasure-giving, we find ourselves continuing to enjoy or to feel good about activities that are natural and they are pleasure-giving. For example, when we take water. For example, when we sleep. For example, when we eat. Those are things that are natural. For example, when people have sex, for example, these are natural things. When we keep warm, when it is very cold, these are things that are natural. Whenever we do them, through the amygdala that I've talked about here, in what we are calling the reward pathway system, the reward pathway circuit, they are normally, the addiction happens in what we call the ventrotegmental area, the VTA. The ventrotegmental area now houses the amygdala and the reward pathway circuit. What happens? For example, umekunywa maji ama umekula. Now, when you eat, your brain produces feel-good hormones or triggers the amygdala and it is telling the amygdala something good happened. And now there's something that is good that happened makes the amygdala trigger the production of the feel-good hormones. And so when they are produced, the amygdala is both regulating the production and also regulating the what is enough of it. Now, okay. Now, when that has happened, there's three things that your brain tends to imagine because it is not very much about the knowledge. Your brain concludes that whatever activity that happened that have triggered the production of feel-good hormones, that thing is good. Whatever happened, you know, the brain does not select if what happened was good or bad. As long as it has triggered the reward pathway circuits, it has triggered the amygdala to regulate and to trigger the production of feel-good hormone, then it is going to also directly trigger the prefrontal cortex. Why? Because our brain has been created in such a way that the father of psychology talked about, called Sigmund Freud, that our brain enjoys pleasure and avoids pain. So our brain is going to concentrate more on that feeling that is good that has happened and omits the part of the rationality where we have talked about the prefrontal cortex. So you realize that these three major areas are playing a key role in our thinking, in our rationality, in our feelings and emotions, and even in what the feeling good that we have. So we have said that the brain concludes it is good. Number two, inajiambia hiyo kitu imefanyika ni muhimu, it's important. Number three, inajiambia hiyo kitu is necessary for survival. So when you do any activity that is triggering the production of feel-good hormones, your brain concludes that that thing is good, that thing is important, that thing you did is necessary for survival. Now, look at when we are using when we are using the psychoactive substances. Sorry, when I say psychoactive, I mean drugs. I mean alcohol, I mean baggy, I mean opioids, I mean, and that is also the pharmacology of medication. That the medication we take is actually coming to just try and it's trying to regulate your neurotransmitters, because that is generally how you function. There is pain. Then if you take painkillers, your brain is triggered to produce its natural feel-good hormone. So indeed, it is not Panadol that will cure the headache. It is your own natural neurotransmitters that will be produced to suppress the pain. So what I mean is, when you are using these substances, or when you do a particular behavior that triggers this production, over time, your reward pathway circuit gets used to it, and it concludes within your brain that that thing is good, that thing is important, that thing is necessary for survival. That is why we are saying that the reward system is the one that reinforces behavior. Because now, if the reward pathway system keeps on being triggered to produce, it concludes that indeed that thing we are doing is very essential for our survival. So it will keep on asking. Later on, we will see that is how now we create the withdrawal symptoms, and they keep on coming back again and again. The amygdala, remember, it has two very important roles within our mind. Number one, that we are saying it is the one that processes emotions, stress, and fear response. And that means that when it comes to the reasoning of the information that comes to our mind, that it is entirely very responsible. So if it is regulating the emotions, feelings and emotions, it's also regulating the aspect or the point of, it is coming with the point of also the regulation of our thought processes, then it is a very crucial organ. That is why there is no reasoning when there is the aspect of addiction and also mental illnesses, because it is busy trying to regulate feelings and emotions more than it is trying to reason or trying to interpret information to gain reasoning. So those three areas, when it comes to the brain, are very important and key when it comes to the regulation of the feel-good hormones. Now, what is addiction? And I think I have defined what addiction is. That it is a chronic relapsing brain disease, and it is not, it is good I say that, it is not a normal failing or lack of willpower. So when we are helping something in addiction, someone with addiction, sorry, or when we are helping someone with these other mental illnesses that are accompanied by addiction, it is not a moral failing, sio upotovu wa nidhamu, yeah? Ama kukosa kutaka kukua sawa. It is good for us to mention and to know that it is something that is just a disease, that we don't have a lot of power over, that we don't have a lot of control over, especially when it develops to the extent of addiction. And when we talk about it, that we need to know that there is a disease model of addiction. When Levi started, he was mentioning that it is a disease, and he was saying we are going to see how. When we talk about it as a disease, it is good for us to know that this is a chronic condition. So I find so many people within treatment. In my long journey and the experience I've had with treatment for addictions and other mental illnesses, you hear a family member or a guardian asking, so ukimtibu atapona kabisa? The question that so many people will ask. But the answer is, yes, they can be able to contain the problem, but we can never say that the problem is finished. What happens is, with proper treatment, that the problem can lay dormant as long as the person remains vigilant and watching themselves not to sink back to the problem once more. So it is chronic. And number two, the brain chemistry. Why we say it is a disease, I have explained that there is that chemistry of the brain that happens that makes the problem keep on coming back, that makes the problem just continue happening, and we do not know what to do about the problem. And so the neural pathways that come with the neurotransmitters. He said that these are the chemicals that carry information through our bodies, because how our body communicates from one organ to the other, from the other to the other, it is majorly through, it is plainly and majorly through these neurotransmitters. And so when there is a problem that tends to become a problem, or there is a problem that tends to affect these neurotransmitters, then we can be able to know that that is a problem in waiting, because now that is the communication of our body from one part to the other through the brain. It communicates via these chemicals of the brain. Then the other thing is the impaired control. When we talk about the disease, the same way, if someone is sick and they are vomiting, we can't just tell them, sasa si uache tu kutapika. Or someone is having a flu and you are telling them, aache kukohoa. No matter how much or how hard they try not to do it, they will still find themselves doing it. Why? Because of what we are calling the impaired control. They are not like willing not to do it. It's not like they are making a decision, they don't want to do it or they won't do it. It's only that they are not in a position to make themselves or to contain themselves not to do it. Yeah, it's not like wao wanakataa ama hawataki kufanya hivyo. Not really. It is a problem that they cannot be able to contain. That's what we are calling the impaired control. And the other thing is that the brain, when it comes to the control, reduces its ability. Yeah, uwezo wa brain yako wa kucontrol, the ability of the brain to be able to control the impulses. And the impulses is the communication within the brain, the communication that is coming with the neurotransmitters is bald or is not very clear, because the brain in one way or the other has been affected by the chemical substances or by the behavior that is affecting the neurotransmitters, both in production and in the regulation of these neurotransmitters. And the World Health Organization, as a major leading medical organization, has also been able to recognize addiction as a disease that is treatable. We will see when it comes to the options of treatment. And like I told you, it has been classified as a mental illness that can be treated using several models of treatment that are available, that we are going to explore as we move along. I don't know if there is anyone with a question so far before we go to how addiction changes the brain. Do we have anyone who might want some clarity there? Not really. Thank you. So how does this addiction now change our brain? I've tried to put some more of the diagram so that we can be able to see. And when your brain is healthy, you can see the impulse on the first image here. The impulse within the brain, the normal dopamine levels, and normally we use dopamine as just the major one, but we have other feel-good hormones that exist that would also get affected based on the substance that someone is using. So it is not only the dopamine, but others as well. But I used dopamine to explain the concept. Now, the normal dopamine levels, you can see there is a balanced reward circuits. Like you can see those impulses within the brain, they are distributed. Yeah, they are distributed all over the brain. And then you can look at it and see the normal brain is not having an area that is majorly concentrated on the feel-good hormone. So there is even distribution of the neurotransmitters of the feel-good hormone. Looking at the early addiction, when someone is in the early addiction, wakati mtu anaanza tu kuzoea, the dopamine surge is very intense pressure and cravings. Unaona concentrate at some point and it is more brighter. Looking at it, the impulse inakaa ni kama the moto imeanza kukua kubwa kidogo. And looking at it, it means that it is creating intense pressure. Kuna hiyo kusikia vizuri. There's a lot of feeling good. Yeah? Because how does someone come to know the high? If I may explain it. Wakati tunasema mtu ako high ama anatafuta hiyo high, exactly nini inakuwa ikiendelea? Remember we said, for the natural pressure giving activities, kama kukula, kama kukunywa maji, kama nini and the others, you realize that this person produces enough of the feel-good hormones. But now here is someone who is doing a behavior or an activity that is also being impacted by a particular chemical. Kuna impact yenye inakujanisha pia na kile ambacho yeye anatumia. Now, when they use these substances that they are using, then you will realize that this person has introduced a chemical. But remember, anything that causes the production of these feel-good hormones, nilisema akili ina decide ni mzuri, ni muhimu, ni necessary ya survival. Kwa hivyo, wakati zinafanyika, our brain in one way or the other is able to start relating to it as something that is good, important, and necessary for survival. Remember, this is chemically triggered. Now that it is chemically triggered, it will tend to be itself. What we say it is that in pharmacology or in the science of addiction, these chemical substances and why they are called neuroactive or they are called psychoactive, sorry, is because they have the ability to affect the psyche of an individual. Energy yako ya akili inaweza affectiwa na hizi kwa sababu ziko na huo uwezo. Uwezo zinatoa wapi wa kuaffect energy ya akili yako? Because when they go to the brain, for example, you take bangi. The active component of bangi is THC, tetrahydrocannabinoid. When it goes to your brain, it will tend to mimic. To mimic is like kujifanya kama photocopy. Na nilisema that is the whole science of making the other medications that are made, painkillers and other medications. They only go and mimic the molecular structure of your natural feel-good hormone. And so, utavuta bangi, alafu itaenda ijifananisha ni kama dopamine. So your brain won't detect the difference between it and the other. So it causes the impulse, or it starts blocking the impulse or the transmission of the natural feel-good hormone. And so your brain starts to get confused. So it will start to produce its own feel-good hormone. So putting in mind that THC directly is affecting the psyche, and now you have produced the feel-good, that feel-good is in excess of what you require. And now that is what people call the high. That is why if you take tea or if you eat, you might not have the exact same high as when you have, for example, wheat, because this one is also triggering the production of the other substances that are there. The other thing I will say is that we can be able to look at, sorry, someone just called. At the end of the day, when it comes to the concentration of these neurotransmitters as it is seen in the second image, it is starting to trigger. So zinaanza kukua sasa, kuna hizo cravings. Wakati hakuna kuna shida because intense pressure imeanza kuzoewa na akili yako. When we look at the third image given there, we will see that the third image is now having the neurotransmitters now reduced. The functionability of these neurotransmitters or the dopamine, there is now the reduction. Yeah, and now the reduction of its impulse is what we are saying is causing the reduced dopamine function. And now if the dopamine function is reduced or functioning is reduced, at the end of the day we will have an issue when it comes to decision making, because reasoning also is also very much affected. Jane, kindly mute your mic. Then there is now in the imaging. This is how addiction causes these changes within the brain. There are a few misconceptions that people have about addiction. One of which is medical, is that addiction is a choice. People feel like addiction ni mtu anachagua. And so many people, even within treatment, I hear people every day telling someone, ni kutaka tu, lazima uweke willpower yako, and you make a choice of not doing it. But the fact is that addiction is a chronic brain disease. There must be treatment anyway. At some point, there must be treatment. And then there is another myth that sometimes people feel like it is lack of willpower. Ni kama huyu mtu pia hataki, ni sisi tunamlazimisha, hatuoni effort yake. But the truth is that the brain changes are the ones that impair control. With the time alizoea kutumia, so brain yake ili change. Yeah. So when there were those changes that occurred, then at the end of the day, there is the impaired control. When the control is impaired, then the brain has got a problem. Kwa sababu huyu mtu haezi control kama kuna shida ishatokea kwa the impairment in the control of the aspect of your brain. So it is good that we come from the darkness of not being very sure about it. But whenever you deal with someone with addiction, just know they are dealing with a disease. It is treatment that will help them. It is continuity of that treatment that will also be able to help the individual. The addiction's impact, this is what it does to individuals. What does addiction do to different people, and how does it do it to them? Number one, that the behavior or the behavioral changes that happen at the end of the day, the compulsive use despite negative outcome, hata wakati outcome iko na shida, huyu mtu anaendelea kutumia tu. Behavioral changes occur, and there is the increased risk taking behaviors. Unapata huyu mtu vitu zenye anafanya ziko very risky. Sio kuenda nyumbani usiku wa manane, sio kuendesha gari kama amelewa, sio kuingia kwa vita za aina zozote. You know, the risk taking behaviors. You realize that the behaviors this person is having are very risky for them, and also posing a risk even to other people, because they are very risky. They are just taking behaviors that are very, very risky. So when we look at these behaviors that are risk-taking, we know that there are some changes. Of course, there is the aspect of what we call unmanageability. Unmanageability is when now these are the things we are able to see that tell us huyu mtu na addiction yake imekuwa shida. Sijui anauza vitu, sijui anaibia watu, sijui amekuwa muongo. In terms of the behavior, then there could be some of those behavior changes that now impact on the behavior of this individual. The other one, physically, that this person could also experience health problems or health challenges, like damage of organs. So mtu ambaye anatumia unaweza pata some organs zake ziko na shida, like the kidneys, like the liver and others, pancreas, the walls of the stomach, depending on what substance this person is using. could pose a threat to their health. So physically, huyu mtu haezi kuwa ako sawa when it comes to the issue of fitness, because the substances could and have that ability of affecting the organs of these individuals. The other one, mental health, that is also an impact. When people are using these substances, they could develop anxiety, they could develop depression, they could develop other co-occurring psychiatric disorders, and these are like the schizophrenia, like bipolar, like other schizoaffective and other illnesses. I think that is what the last session, for those who are there, that is what Ada was talking about. The other co-occurring disorders that occur together with addiction. It could easily cause those mental illnesses. Social consequences, when it comes to how this person relates with other people, how they relate, uhusiano wake na watu wale wengine. Huyu mtu kuweka relationships, both intimate ones or not even intimate ones, even at work, job loss. There is sometimes the aspects of financial hardships, because huyu mtu amepata 5,000, badala afikirie vile hiyo 5,000 itafanya kitu, ameitumia tena, shida imekuwa even more. And you look at them and you're finding there is a problem that is continuing, and a problem that keeps on coming back. And at the end of the day, huyu mtu unaweza mpata ameji-isolate. Kwa nini? Because of guilt, because of shame, because of frustrations and all that. Because of probably they developed other mental illnesses. These people tend to also isolate themselves. So when we talk about addiction, it affects all the aspects of being in different ways. It affects them in very, very different ways. So it is upon now us to also check on, when we are talking about this person having a problem, in what areas are they affected majorly. There are causes, because I talked about when we understand, we know the causes of addiction. Those are signs and symptoms. Number one, what causes addiction? I will start by saying, before I go to these ones that can trigger it, addiction is caused by heightened tolerance to a behavior or a substance. Heightened tolerance means that huyu mtu anahitaji some higher amount for them to attain or to achieve the original feeling they got when they started using. So huyu mtu kama for example alianza pombe, ikiwa siku ya kwanza alikunywa chupa moja na akasikia sasa ako high, with the time anahitaji chupa moja na nusu, chupa 2, chupa 4, chupa 10. Inafika mahali hata sasa bia haimsaidii, anahitaji nyingine more concentrated. And that is what I mean heightened tolerance. Over time, when the body demands a relatively higher amount of the substance to attain the original feeling that we can be able to talk about. Then there is also the genetics. When we talk about the family history, and the history of addiction mostly increases with the vulnerability within the family. For people who have had issues of genetic predisposition, it means it's not like these genetics, and it's good I clear that, because there are people who assume that genetics would cause. Normally, the genetic predisposition won't cause the addiction, but what it is that this person with exposure, they are at more risk. If I am predisposed genetically, tukianza kutumia na mtu hayuko predisposed, I will tend to become an addict more faster than that other person. Why? Because already I am more predisposed. Genetically, we have mutated to have the aspect of more risk to addiction. And so the moment I expose myself, I will get into addiction very fast. The genetics. Trauma. That there are some things that would have caused emotional pain or injury that sometimes cause the pain, or cause them to want to hide by using the substances. And that is why in addiction treatment is very important to incorporate the trauma-informed care. Most probably when we have a chance, we will talk about it another time. The trauma-informed care is to check the underlying issues, because things like trauma are underlying issues. They are the things that happen to us, and as they happen to us, they are things that can keep on coming back to us, especially if we are not careful on observing or knowing what we ought to do with the trauma that is coming to us. The other thing is early exposure, especially when someone is exposed to these substances at very early age, wakati ziko na zinapatikana sana. For example, you find that people wenye kwao wanazaliwa wanapata mzazi anatumianga pombe, for example, anavutaga sigara, anafanya nini, sorry, and they get exposed to it at early stages. These people will tend to become more predisposed again, and they can also have addiction risk that is more increased than the people who are not having or suffering from the same problem that the others who are within the family have been experiencing. So kama huyu mtu amekuwa na exposure ya mapema, hata mahali ziko mingi, when we talk about the reasons why people use drugs, one of the reasons is availability. Kwa sababu iko and everybody is using, it's not like it's a big deal. Everybody sees it as something just very common. Mahali ziko mingi sana, people will tend to be more, the population will tend to be more of the people who use. No matter we say that one of the ways of trying to regulate and ensure that we are also fighting addiction is ensuring that as availability is also limited. But as soon as movement, as much as we want to control it, and it is all over and available at any point, then it's almost a losing battle that we will be talking about if we don't regulate on that. The other thing is the environmental factors. And the environmental factors we will be talking about today are like the peer influence, are things like the availability of these substances, are things like the lack of social support that can sometimes contribute to the risk. So when there is the risk that keeps on coming back, and environment-wise that the people are becoming more predisposed to these problems, then it's important to know that with nothing happening, then it could also cause the addiction. Wakati tunakuwa na poor role modeling, yeah? Watu wanaangalia mtu anaona ni kama yeye amefika mahali amemake it, yeye hutumia, hata utawasikia wakijustify. Si hata fulani anatumiaga nako ameenda mbali ama amefika mbali, you know, the peer influence. The things we will be looking at as the environmental factors, that availability, social support, and sometimes even creation of awareness so that people can understand that it is indeed a problem that needs them to know how they address. It could be the factors. These are the risk factors. People who are predisposed to these factors are going to be at more risk of developing addiction than others. The diagnosis, there is the clinical criteria through the DSM-5, and the things we look at, the 11 criteria we use across the impaired control. There will be social impairment, there will be the risky use, there will be pharmacological indicators of the issues we talk about. The issues we talk about, the organs or the body not being in a position to contain or control it. We will be talking about sometimes severity, when it is classified as mild, moderate, severe, whatever. And then there is also the symptoms that are present. So when we are talking about the DSM, those are the 11 factors we look at when we can say that someone has addiction. So you don't just look at someone who drinks and say they are addicted. There must be those evidence-based also issues to look at. Medical assessment is where we conduct physical examination to the blood tests, screening, where we do also assessment, using the tools that we use, like the assist, like the ASI, like the dust, must. You know, they are just tools that we can use when we are assessing. When we assess for these substances, then we are able to look at them with an aim of trying to see, do we require attention? And at what area do we require attention? Do these people experience withdrawal symptoms when we have not been able to address it? Do we at times find ourselves not being able to know what to help them like? And then there is the number 3 form of assessment, which is psychological evaluation. And the mental health professionals, like the psychologists, addictions counselors, like clinical psychologists, psychiatrists, doctors, psychiatric nurses, all these people could play a big role also in assessing other underlying issues that could be there. And this is to help to also structure evaluation on the mental aspect of being of this person, so that we can know, do we have other co-occurring mental health disorders, or so that we can be able to personalize the treatment. We say treatment might be similar at some levels, but also might be must be personalized to meet individual needs. So even that is the criteria we use at Maranatha ourselves, that a person has to be seen and looked into at different scopes of being. Is it medical? Is it psychological? Is it, you know, so that socially within the family scope, so that we can say, as we diagnose, that someone is not coming with so many psychological issues and we are mistaking them for the presenting issue, which might be addiction. We're not saying that those issues would rule out the issue of addiction, but without addressing those, then addiction also is not going to be very practical in terms of treatment. That way, you can be able to diagnose addiction. There are some options of treatment that we can be able to look at. And treatment, sometimes we say that it works best when it is integrated. And we say the integrated model of treatment is when we have the biological treatment, we have the social treatment, we have the psychological treatment, we have all these models of treatment. And as we look at these models of treatment, we are trying to integrate them so that they can be able to meet the needs of the person who is sick. So the behavioral therapies, and of course, therapy, by therapy I mean counseling, based on the issues that are presented on the person. And why I'm saying behavioral is because also addiction is also a learned behavior. So there is no way you will do it without having the behavioral therapy interventions and also motivational intervening, because like we said, there are so many also who do not appreciate, because also the addiction is characterized by the denials. You know, mtu hataki kukubali kuna shida and all that. So us trying to check into how we can help them using these patterns. The other one is medications, and medications is the medications that help to deal with withdrawals management and also long-term maintenance, where there is a big problem with the neurotransmitters we talked about. Then we must involve medication so that we can be able to stabilize them. Maybe they have insomnia, maybe their mood is distorted, maybe they are having psychotic episodes and all that. We must include some medications at some point so that we can treat those that will not cure by basically just doing the counseling to these individuals. The other one is support groups, introducing the peer support programs like the 12-step groups, and also the AA, Alcoholic Anonymous, Narcotics Anonymous group, Sex Addiction Anonymous, and all that, the support groups. And this can begin within the early stages of recovery in treatment, where they get the group sessions and also learn this step work and all that to be able to maintain or sustain the recovery at early stages. And then there is rehabilitation, where we have inpatient and outpatient programs that offer structured environment. This structured environment is very comprehensive for recovery. It is trying just to look at the structured environment, looks at both the presenting issues and the underlying issues, incorporating also the family to involve them, and at the end of the day, social life ya huyu mtu, and also we look at the aftercare programming when it comes to the outpatient part. So the treatment options are many, but they all are based on the severity of the individual. There are people who can basically not go through the outpatient treatment before they are first admitted to stabilize and to get better. So it depends on the assessment of particular individuals. How does treatment work in the brain? Is what we call the neuroplasticity. And this neuroplasticity that we talk about, it is helping us to understand or to talk about the brain's healing power, the path to that recovery. Because the brain, normally, it has that ability to recognize or to reorganize itself to form a new neural connection through life. And so sometimes addiction treatment helps to be able to repair that damage, to leverage the neuroplasticity, because with the time, the brain could adjust, to incorporate the behavior that already came in. So if we do not look at how we can incorporate treatment, then we are not going to repair the damage that is already caused. And this damage that is already caused, again, it can be restored to have a healthy brain functioning when we are able to put in work of treatment. Now, we can restore the reward pathway circuit. Like I said, most of the medications tend to balance the neurotransmitters. They tend to help us work on the feel-good hormones. The neurotransmitters, I said, are all the feel-good hormones within the body that tend to be imbalanced. And because addiction disrupts that reward pathway circuit, it is only sustained by the treatment. Now, the receptors can recover, and the brain also can be able to have its own natural way of restoring itself. But again, it is when there is treatment and abstinence from the substances. When we do that, we can always rebuild the decision making, because it helps us to also strengthen the prefrontal cortex, and that is the brain region that is responsible for these impulses. So if we do not incorporate treatment, then at the end of the day, we are going to have a problem when it comes to the issue of treatment, because the brain, at the end of the day, whatever I'm calling neuroplasticity, it could get to a point where someone is now having chronic issues with their brain, such that the brain has adjusted to try and suit or to try and favor the behavior that this person is possessing or this person is having. So when we give treatment, it means we are restoring the brain so that we can restore the reward pathway circuit, we can restore the decision-making capacity, so that at the end of the day, the person is able to come back to themselves in a wider scope of view. The benefits of treatment that we will get there, like we have said, we have the recovery assisting us to reduce the rate of relapse, because we said if someone stops on their own and they don't know how to deal with withdrawals, for example, someone has abstained, they are not having sleep, they are having insomnia, they don't know what to do with the lack of sleep. At the end of the day, it will be a bigger problem to this person if we are not, again, exposing or putting them in a position where they need to heal or they need to understand what they can do. So treatment helps to reduce that rate, to know what they can do to remain clean or sober. Yeah, and then there is also the improved quality of life, because at the end of the day, if someone has these physical issues we are talking about, if someone is having these mental illnesses we are talking about, the quality of life is not very right. Sometimes even the duration of living is limited, because with these illnesses, even death at times is also very near if nothing happens. And mind you, we always say that for addicts, when they are in active for persons with addiction, when they are in active addiction, even then sometimes is a viable option. It's not like something that you mention to them that is very scary, or something that they would have a problem sitting very well with. sometimes they feel like that is also a viable option, especially when they have apathy, when they are depressed, when they have other mental illnesses. So even treatment sometimes helps us to improve the quality, because we are having better relationships with other people, our physical health is better, and other areas that we require to observe and see how we address is also looked into with the treatment. I do not know if there is anyone who would want any clarity anywhere before we proceed. There are just some few stories of recovery there. Do we have anyone with a question? These are just people I picked from the big book. You can always find the big book and find so many stories. Big book is the Alcoholic Anonymous big book guidebook. If you just go somewhere and you say you want the AA book or the big book, you can always get it for addiction. Yes, Levi, I see you have a question.
Yeah, thanks, Mr. James, for this forum. My question will just be probably when we look at recovery, what are the timelines that you always look for, maybe to assess that the brain, or maybe some of the things, some of the parts that are that are broken as a result of addiction, can go back to normal once people in active addiction, start abstinence and they start working out on their recovery program. Does the brain or does the body normally go back to, or maybe get back the balance that was initially there before people started substance addiction and so on and so forth? So maybe this would be important for you to clarify. Thank you.
Okay, thank you so much, Levi. Very nice question. Normally, I will say that it depends on the severity of the individuals. The more severe it is, the longer it might take, and also how much you work on the process of recovery is very much dependent. So normally, like for us, what we do an aftercare for about 1 year, but it is good and important to note, as much as the neural transmitters can go back to a normal setting, it is, like we said, it is a chronic illness. So at no point we are going to have this person go back to a factory reset. And a factory reset, I mean, there is no time when we are going to say ati sasa huyu mtu hata akitumia sasa atarudi ni kama anaanza tena. Huyu mtu at the end of the day atajipata akianza tu ataendelea from where they left, you know. So what happens is that the problem lays dormant in the mind of this individual as to until such a time, and that is why we say it is a lifetime process where you are working on yourself continuously. But the duration at which we can start saying probably now the person is getting stable properly, like for us, is about 1 year when we do the aftercare, the outpatient program, so that we can ascertain at least someone is a bit more stable. And sometimes even after then we continue supporting the person because we are saying it's a lifetime process to continue taking care. If in case you use, then you go back to where you stopped it. Yes, Anne?
You talked about sometimes being hereditary or genetic, maybe where people in their home they take maybe the alcohol. So I don't understand where now this person comes in and it's an addict. How long do they take for them to recover from addiction, being in a genetic way?
Well, like I said, the genetics, what they do is they pose a higher risk of addiction. But again, like I said, the duration of treatment depends on the severity of the individual, because again, if they are genetically predisposed, all it does is that it puts them at more risk of addiction, and when they get into addiction they struggle quite a lot to recover, because genetically wao genes zao zimemutate to accommodate the addiction. So it can take a toll on some people, only that it requires proper treatment so that they can be able to access the need or the help they require, and then they can be able to maintain. But again, the duration it will take them might depend very much on the severity of the problem. So kuna haya anaweza kuwa yes, they are genetically predisposed, lakini amesaidika wakati hajakuwa already ako very badly off, na kuna yule anaweza kuja kama hata hayuko genetically predisposed na akue ako very badly off. But yes, for those who are genetically predisposed, what you are saying is genes zao zimesha mutate to have the problem of addiction. It could happen, it could keep on happening.
And when it comes to the relapse, you will find maybe a client has gone to the rehab and has finished the 90 days and joined the AA program, but after some times they relapse, and every time they relapse, they have to call you and say sorry. Then they stay clean for about maybe 1 or 2 months, and again they relapse. So what might be the problem with maybe the client, or is there something that can be done for them not to go back to the usual habits?
Okay, Lewis, you can write that question for me, then I answer it towards the end.
Sure.
Okay, did I see Dixon asking a question before I proceed?
Hi. So I wanted to ask.
Uh-huh.
So if for instance someone was
Mm.
addicted to alcohol, he goes
Uh-huh.
through therapy, gets well,
Uh-huh.
and then again starts to use something again. Is that advisable? Like for instance, he considerate just not to go back to alcohol. Is that advisable?
What, okay, what we call cross addiction. Okay,
Yeah,
that one too.
to help
Okay, thank you.
with the previous addiction, not to go back to the previous addiction that they had, or they not to they start using something to help with the addiction.
Okay, okay. Sawa sawa. That one Levi is also noted for me kindly. I will respond to it. So thank you for those questions. I am going to answer the ones that have been asked. Yes, Mukami.
Thank you very much, James. This is insightful. I have a question.
Yeah.
I wanted to ask, you've mentioned about giving a full-time or a lifetime support to the addicts. Sometimes it can be very frustrating, and especially when you've really done to the best of your perfection. At what point do you think we should stop enabling them? Like, at what point do you think we should just let them be? You know, because sometimes you're like, oh, I don't want him to go back. Let me keep on trying. But I think we keep on enabling them. So maybe you can give a bit of, or maybe you can explain further by saying, what do you mean by full time? Even when they keep on doing one and the same thing, one and the same thing. Thank you.
Thank you so much, Mukami. Levis, note that one for me also. I will respond to those. Thank you so much for those questions. I will be looking into them because of the aspect of time. Why stigma hurts? Because we talked about why most of the people do not find it very easy to seek for recovery. The issue of stigma, is when someone feels like they are going to be humiliated, they are going to be embarrassed about the problem, they are going to basically have a problem when it comes to the response that might be there or that might help them to resolve or to deal with the problem they have at hand. So us asking ourselves, what is the point at which we need to avoid this stigma? Because why stigma hurts a lot to the persons who are having the problem is because sometimes the stigma is not only to the person living with addiction, sometimes the stigma is even with the family, especially when they are very much frustrated of whatever is happening. Number one, it's good for us to know that stigma prevents people from seeking treatment because they fear that judgment. Yeah, so mtu anaogopa judgment sana, and so the stigma makes them avoid seeking help. Number two, it increases the feelings of shame. It increases the feelings of isolation. It worsens the mental health because this person is just feeling they are going to be made ashamed. They are going to feel humiliated when they talk about their problem and all that. So it increases those feelings of shame and isolation. Barrier number three, it reduces the social support from family and friends and also the community. The kind of support that this person might require is very much reduced because of stigma. Because when they go seeking for help, it might not come their way the way they might expect. And so they are going to feel very much stigmatized or not even be in a position to address their issues or their problems. The other thing is creating the systemic discrimination in healthcare, employment, and housing, especially when it comes to a person being known that they have struggled with addictions. Then you realize that so many people have a lot of fear with them, and they fear that they might go back to the problem, they might have issues with them in the future, and so many people tend to avoid them. So sometimes there is that systemic discrimination that keeps on happening to these people, and it keeps on happening to these people as they do not know what to do. And that is why we need to address the stigma, and we need to address this challenge together. And addressing this challenge together means that we need to take some actions, and some of these actions, like the actions that are there, will very much require us to observe or to look at some things we need to do. Number one, you're saying that you use the person first language. Yeah, other than when you say an addict, nowadays you're saying that you even do not refer to them as an addict. You know, you need to refer to them with person first language, like the person with addiction, the person living with disability. Don't call someone disabled, for example. The same way, don't just call someone an addict, because that one in itself is already stigmatizing. So you're saying the person living with addiction or the person with addiction. Number two, something that we can be able to do as we try and come and challenge the problem of the issue of stigma is sharing accurate information about addiction as a brain disease with other people, so that people start looking at it as a behavioral issue. People stop looking at it as just something that can be played and it goes away. People have made it a spiritual issue. When kuko na roho ya kukunywa, it's not like I'm against spirituality, but is it accurate information? Yeah, but there is no real experiential, experimental evidence as part to that. Are we able to give that accurate information that this is a disease? As much as we want to incorporate other aspects of treatment, that we also want to appreciate that this is an issue that is keeping on coming back to this particular person. The other thing is appreciating that support in treatment is very important. So when we support people to access treatment within the community, workplace, and all the spaces we are in, we advocate for them to get help. We advocate for them to get better. It is a very, very important thing. The other thing is we can listen to these people without judgment, and as we listen to them without judgment, at the same time, we offer compassion to those who are struggling with addiction. So if we are able to offer, compassion, listen to them when they are raising those issues, be able to know what we can do to assist them without judging them, is a very important area as well that we are going to appreciate together as a team. So those are some few actions that we can take to be able to challenge it. And for families and communities, we need to encourage people by offering an understanding and the emotional support without judgment. Sometimes I understand there are some people who have gone through it up and down, in and out of the problem. I have not heard people complain and feel frustrated and feel angry and judge people because they are saying amekuwa na diabetes for the last 20 years, iko juu, ameenda hospitali, amerudi nyumbani, anatusumbua. As nobody who gets angry about that. Why? Because we are taking it as a disease and a chronic one. But no, this is also a chronic disease that we need to know that it has a tendency of keeping and coming back. The same way you don't take a person with diabetes and start telling them, sasa wewe kwani ulijipea stress, kwani ulikula ama ulikula vitu zenye uliambiwa. We don't do that. We first take them for treatment and then we can try addressing where did we get amiss that we got that back, back and forth. The same way with this, we are going to encourage and see how we can actually support people without judgment, and also we offer some understanding to them, because that in itself could be a treating agent. Understanding these people in itself is also part of treatment. Resources, sometimes you need to connect loved ones to treatment programs, sometimes counseling sessions, and also support groups where they can go and get some support. That means that for we as a community and as a family, we also have a role of also putting them into treatment and also encouraging some resources or committing some resources. Safe spaces, creating environments where recovery can be flourishing, or where recovery can, go on. You don't have someone in recovery and where you're taking them is a ghetto, and the ghetto where everybody is using everything, where everything is everywhere, and we experience their recovery to flourish. Sometimes you need to put them in safe spaces, especially in the early stages of their recovery. We need to put them in a very, very safe space. The other thing is advocacy, where we can champion for policies that expand treatment access and also reduces stigma. Sometimes you find us moving around, we are in schools, we are in churches, we are in where we are doing that because we know we need to increase on advocacy. Many people need to know that this is a problem, this is a disease that requires attention and treatment like any other. We all have a role in creating advocacy, because it also plays a very big role in reducing stigma, where people start knowing it is a problem that has many people, and it's a problem that can be dealt with by addressing the issue. The other thing is now the advocacy that we have for better access, and this is where you're going to break down the barriers to breaking these barriers to addiction treatment. And it is because sometimes we need to have the insurance coverage. Sometimes insurance plans can still provide for limited coverage at some point, but there are also those people who have covers that cater for their treatment in the addiction areas. Funding for programs, sometimes you can seek fundings where you can be able to get government, private funding to be able to do programs that actually help other people to create awareness and to also learn how they can come out of their addiction, how they can get the treatment options, and how they can continue addressing the issues that are coming their way. The other one is having some equitable care for everybody, where we now are saying that care needs to be equal for everybody, equitable, where everybody can be able to access it.
Oh no!
And this is by when we advocate and continue seeking to practice to have these people engage more in the options we provide to their treatment and the care that they require within their addiction. When we talk about the addiction, we are talking about a problem that, like I started by saying, is not noted as a serious problem by so many people, including government. They don't take it as a very serious medical problem. Most of the people look at it as something that can be wished away. But indeed, it is something that has got a greater impact than it is basically assumed. Impact yake ni kubwa sana than the way it is put to us. If we do not get more careful on it, it's a problem that comes back to us to haunt us together. It is a public health issue and a crisis. Like there are some areas we have gone, especially in the areas of Kiambu, in the areas of Mount Kenya region. They are having a very big crisis. Not like it's not anywhere else, but it is a very, very, very huge public issue right now. The issues or the cases of suicide related to drugs is very high. Related to mental illnesses, very high. Those mental illnesses that have very high cases, relating them to addiction, also very high. So the crisis requiring a collective action from all of us, and starting from the broad social impact, that we can help the ones who are already in it, because it affects the entire community. You know, it strains the healthcare system, increasing crime rates, like in our country right now, crime rates all over and everywhere. Sometimes the workforce productivity also is reducing, and also there are a lot of burdens for the families and the social services, because now all these issues shadow down and come back to the same issues that are put or that are placed to us. So we need to know how we can have a collective responsibility together. And addressing this, it is for us to coordinate efforts across the government, across healthcare, across the education sector, and across the community organizations that can help us to be able to expand treatment access, support recovery, and also create awareness for those ones who are not trapped in it, so that they don't sink into it and actually dive into not knowing what they do for themselves. We can do that by educating and creating awareness so that we can reduce the myths. And these myths is that we can be able to deal with the misconceptions that are going to also place stigma and with a lot of understanding. We replace that misconception with understanding. We have early interventions before people are already stuck and people are already lost. And I always encourage even parents, as soon as you hear your son, your daughter is having a little problem, seek intervention at that point. You don't say ati huyu hana shida kubwa, angekuwa na shida kubwa ingeniwori. They are on the route to the bigger problem. So addressing it before it is very huge, early interventions is very important. Empowering families so that you can be able to give families, like we who are here now, are more encouraged. Most probably we know now we can be able to work on ourselves better so that we can support these people better. Why? We are more empowered. Can we be able to empower families so that this knowledge is going to give these families tools of support so that they can be able to support the loved ones effectively? The other thing is the community impact. And community impact is where we have the informed communities that create supportive environments for recovery and healing. And when we have that communities informed and creating awareness programs and all that, we are going to have healing and recovery that is having a better environment where people are not feeling judged, they are not feeling stigmatized, but are feeling supported. There is research that is continuing in the addiction science, and there are new medications that are coming through so that we can have medications that are targeting specific brain receptors that are involved in addiction, because that way it is going to offer more effective ways to reduce the craving and to prevent relapse. Maybe like even you find there are some drugs for alcohol zenye mtu anapewa akikunywa anasikia kutapika nini, there are such. We will be able to be looking at that. Then there is the brain stimulation therapy, so you can have the therapeutic interventions dealing with it, and also personalized treatment for individuals. How can you help these people? Because knowing how you help these people is very important. Educating yourself and others about addiction as a brain disease. Volunteering, maybe your time, maybe at treatment centers, recovery programs to see how you support them. You can donate to organizations, you can support people in addictions to get treatment. You can also advocate for policy changes to improve treatment access within your community, within the country. Those are some of the actions you can do to be part and parcel of the change. And the resources for support are written there, areas you can get resources, like the National Addiction Treatment Centers, we have facilities. You can seek support in AA, NS, Smart Recovery. You can seek in the NACADA hotlines. I have put, you can even seek support to us in Maranatha Restoration Homes. We could always be there to support you. And in a summary, that addiction is a chronic brain disease and not a moral failure or lack of willpower. The treatment is going to work, especially when we include the evidence-based therapies that will help the brain and heal to restore the balance. And we can be able to know that recovery is very much possible with proper support and intervention. And reducing the stigma is essential for encouraging people to seek help and to improve the outcomes of recovery. So at that point, I wish to thank each and every one of you for your attention and for joining this session. The science of addiction is a very, 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 very long topic, a very long topic. So I tried my best to try and compile and put them together so that we can be able to address it all together. Yes, Lewis?
Thank you so much. I can see everyone is clapping for James. Thank you so much for the presentation. In the interest of time, I have a few announcements. And the first announcement is this has been one a series that we are running. We have another very powerful and beautiful webinar that we're going to be having on next Saturday on family. We're going to be hosting Professor Catherine Gashutha. She's a marriage and family therapist. And we're going to just be talking and we'll just be building on what we've learned today. And the topic, I just want to give you a sneak peek on what it is that we're going to be doing next week, because it's a privilege for us to be able to host her next week. She'll be talking about the role of family in long-term recovery. And so we'll be looking at why family involvement improves treatment outcomes and relapse. And we will be answering, I think it was Margaret's question, where she asked a very good question on when do we stop, or how do we, when do we mark the line? When do we say that enough is enough? This is or how do we know how to show up for these individuals? Because that's a very one of the questions that every family member asks. How do we support these people better? How do we come through for them? And so that's a question I feel would be best answered in a whole presentation by a professional who has been doing that, and she has specialized and done a lot of good work in the area of marriage and family therapy. So, James, I don't know if you can answer very fast a question. I'll just bring them together and maybe you can answer them together. But also know we are going to be having a series until the end of August on these areas, especially on addiction and how we can support people around those areas. There was a question that was asked on the cross addiction, and the other question was the first question there, because you said the other one would be
How to
answered by
deal
Prof.
with relapse.
How to deal with relapse when our clients finishes the program.
Okay. Thank you, Lewis. I think on the issue of relapse in treatment, relapse, I always say, and maybe within, I also answer this within my experience working with clients with addiction and also mental illnesses. A relapse sometimes means it is maybe we did not address the right problem, or we addressed the right problem in the wrong way, or we addressed the right problem in the right way, but probably we did not give it the correct follow-up. So sometimes the continuum of care is very important because, like we said, it is a chronic problem. The continuity of the much we engage with these people increases the success rate of how they can sustain their sobriety. But the more we do not have a continuity of care, more we do not have aftercare programs, and at the end of the day, they might be hooked back to using again because of the issues that will be coming up. And that also comes with people going with cross addicting to other issues. It means then that maybe they did not get the whole point of what addiction would be, because if they understand addiction greatly, they will know that even crossing it back to the other one, it is only a time bomb. At the end of the day, it is also going back to the same hole that we were in. So we cannot say that it is advisable for someone to come from this to this other one. Even there are people who come from alcohol and they start taking tea in a very bad way, all the time, very concentrated and all that. At the end of the day, we are saying it is where you are training your brain to survive without basically depending on particular substances, other than where you would just stay and hope and wait on, depend on a particular thing for you to survive. So when you're coming from one particular thing to the other, if you're only taking the problem from Nairobi, it is now in Thika. But it's the same problem, and it's coming to haunt in the near future. That is also a way of saying that someone is in the journey of going back to the same habits. I hope I answered those two questions.
Oh, yes, James, you've been able to answer that. So thank you so much for the presentation. I want to appreciate every one of us who've been able to join tonight's session. I know we've crossed our limit of time, but we also understand that it is one of the topics that requires us to really tune in and just ask ourselves questions around addiction and understanding if it's actually a disease, then how do we move forward from that? And I do understand the questions that are coming out, especially when someone asks how do we mark the line? When do we say that this person needs to figure things out for themselves? When do we limit, generally, how do we support these clients or these individuals in the best way that we can be able to do? And it comes because there's a lot of issues. James mentioned earlier, the signs and symptoms are the issues that we see every day. When someone steals, when someone sells things from the house to buy alcohol or to buy a substance, when someone engages in legal issues like maybe mugging or even becoming very violent and beating their own family members. Some of these things, when we look at them, they look like very behavioral and moral issues. And then we find ourselves struggling to believe that these people are not responsible, or there's something beyond just the behavior. So we come to a place in that intersection where we are now understanding that we actually are dealing with a menace, and that is addiction, and that it's also a disease that before we can talk about any other thing, we need also to look at it from a place where it can go through a process of treatment, and then we can look at all these other areas. The last thing that we say in Maranatha is that treatment is not complete without looking at all the areas of that person. And so we look at psychological issues, we look at physiological issues, that is their body, and then we look at their socio-economic spaces in their lives. That was why James was talking about the environments and the spaces that these clients are in. It's important that we
Excuse,
look for all those.
Lewis.
Yes.
Kindly Ian, mute your mic. There is some noise in the background. Ian, kindly mute your mic.
Okay, I've muted him. So
Continue.
we have to bring this person. We have to take care of every part of these individuals. So thank you so much. If there is no any other question, I will just read again the number and we'll send you the presentation. And please, if you want, we can add you in our group so that we can be sending you updates and our links for the other meetings. The number is 0716 537 946, as you can see it on the screen, or 0704 026 704, or email us at info@maranatharh.co.ke. As we said, we are a treatment center dealing with mental health and addiction counseling, marriage and family therapy, teen and adolescent counseling, or even drug tests. So with that, I just want us to say from wherever we are, the grace, and then we can have a lovely night until next Saturday. So the grace of our Lord Jesus Christ and the love of God, you can unmute, and the fellowship of the Holy
The
Spirit
fellowship of the Holy Spirit be with us now and forevermore. Amen.
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 God
Amen.
bless
Thank
you
you.
all.
Thank you so much,
Thank
Jaymo.
you.
Thank you. God bless you.
Thank
Thank
you.
you.
Asante, asante. Thank you so much. Have a lovely night.